This is the first presentation in genitourinary imaging prepared by Prof. Sharaf. First, about the anatomy, we should have an idea about the size of the kidney. In below 1 year it is 5, more than 1 year it is about 7, in adults it is about 12, and if you see that 5 plus 7 equal 12, it will be easy to remark. The liver, spleen, and renal cortex are more than renal medulla. This is the echogenicity in ultrasound. Renal vascular anatomy, renal arteries. We have the first order artery. This is the main renal artery at the level of L1 or at the upper level of L2, it means the pyramids. And fourth order are the arcuate arteries communicating these interlobar arteries. There is tiny vessels perfusing the renal capsule originating from the main renal artery and branch of the renal artery or other retroperitoneal arteries. It's not constant, but these are different than those supplying the renal parenchyma. The renal veins are single right renal vein without major extrarenal tributaries, and single left renal vein with several extrarenal major tributaries, including the left adrenal vein, left gonadal vein, lumbar ascending lumbar, and hemiazygous veins. This could be drained by the left renal vein. So we have capsular vessels, capsular arteries. These are coming from the main artery, the main renal, or a branch of the renal, or any other retroperitoneal artery. Renal veins, and on the right it is one single renal right renal vein with no major tributaries. On the left renal vein receive gonadal, adrenal, and lumbar, ascending lumbar, and maybe hemiazygous veins. Normal nephrographic phases. After you give contrast, the contrast will perfuse the cortices since they contain the glomeruli, and this will result in what we call the vascular phase or the cortical arteriogram. This contrast material visible within the interlobular arteries and within the main glomeruli. It is apparent 10 to 25 seconds after intravenous injection and are seen as semilunar, thick, dense, enhancing parenchyma representing the cortex. The second is the cortical phase, cortical nephrogram. After this vascular phase, where the contrast can be seen within low interlobular arteries, it goes into the capillaries. So contrast medium within the cortical capillaries, this occur between 25 to 70 seconds after injection, and exclusive renal cortical enhancement with minimal enhancing renal medulla. You will find the kidney converted into a nephrogram, all of it, except for the medial aspect of the renal medulla. So we have vascular phase. This is a cortical arteriogram. You may see, you may be able to see the vessels, and cortical vascular phase, cortical phase, which is considered the nephrogram. And then the parenchymal phase. And here the nephrogram will continue to fill the medullary medial aspect of the kidneys. Contrast materials are filling the loops of Henle and the renal collecting tubules. The loops of Henle starts from the glomeruli. Glomeruli are present at the cortex. Loops of Henle are extending into the medulla, into the pyramids, and then back again to continue as renal tubules which are non-functioning. and they are only passages. This occurs 1 to 2 minutes, 60 to 120 seconds after injection intravenous. Enhancement of the it denotes enhancement of the both cortex and medulla, the most valuable phase for detecting renal mass. So long the kidney can be casted by contrast as a shadow, then any defect or any hypervascular mass will be evident. Then starting the contrast to go into the renal tubules, collecting the tubules, and this will start as brushing of the renal pyramids at the papillae and filling of the small renal calyces. This occurs 2 to 5 minutes. Gradually this will fill the renal pelvis and go into the ureter. This depends on the amount of contrast given and the capability of your machine in conventional X-rays to get good contrast films. And in CT it is easy to detect any trace because CT is sensitive to the density of the metallic contrast. Kidneys CT density is 30 to 45 without contrast medium. The renal cortex after contrast reaches up to 140. The time to corticomedullary equilibrium, where the cortex and the medulla are both casted by contrast and giving the shadow of the nephrogram, is the average time is 1 minute. Contrast excretion into the pelvic cell system takes 2 to 3 minutes, up to 5. The garota fascia thickness, sometimes seen in an MRI or in CT, is 1 to 2 millimeter. Lymph nodes at the region near to the kidneys more than 1 centimeter are suspicious for pathology. These are some normal parameters. This is the normal appearance of the intravenous pyelogram, where the kidneys are almost symmetrical even in branching, and usually we have 18 to 20 small, what we call minor calyces, and then this drain into major calyces, which can be divided into upper, middle, and lower. And here it is the pelvis, renal pelvis is splitted, same as here. This is usual finding. And then we have the in the kidney, the length of the right is a little bit more than the left, but there should be symmetry. The interpapillary line, that is the line passing in all these tips of pyramids, should be parallel to the surface of the kidney. This will be discussed more after. And the distance from the lower pole calyx to the surface of the kidney are usually identical on both sides, same as with the upper lobe calyx with the surface of the kidney. There should be some symmetry. Ureters are passing along the transverse processes and getting along the curve of the pelvis into the bladder. The distance in between the insertion of both ureters is called the interureteric ridge, and it is lying posteriorly, and sometimes if there is some obstruction or prostate or anything at the bladder neck, the bladder above the interureteric ridge sags backward and cause a small out pouch posteriorly. Remember that these are the sites of the region of weak inguinal fascia, that the bladder can take a shape of bulge on the right and bulge on the left, and these are called the bladder ears. And again, you should be careful that the shape of the pelvis is indicative of sex of the patient. So here it is a female, she is a female, since the pelvis is round and smooth and wide. And at the same time, don't forget that this film is giving you an idea about the soft tissues in the abdomen, in contrast to the delineated kidneys. So these are the kidneys, and here is the psoas, and here is another psoas, and this is the region of the liver where there is no gas, and this is a gastric rugae delineated with gas. This is some gas at the region of the cecum, and this is some gas at the region of sigmoid. These are the normal distribution of gas: stomach, cecum, and sigmoid. And the soft tissues: liver, psoas, spleen, and here the spleen is within normal, since it is not passing below the line drawn by the last strip. These are some hints about the conventional study in normal IVU or normal IVP. Now, if you are doing an intravenous pyelogram, you will use compression, and the compression here is intended to press on the ureters at the pelvic promontory, at the pelvic brim, thus giving this appearance. This is normal, and this is normal for the same patient before compression, without compression, and with compression. Here you will have a chance to see well the arborization and the chelices, whether minor chelices or major chelices, better than in this one. But in all cases, take care that the tip of the pyramid is making a cup, and this cup should be kept. A cup is normal finding due to the tip of the pyramid, and of course you know that there are 8 to 12 pyramids in the kidneys, and according to the number of minor chelices, which may reach into 18, because each pyramid open into a small minor calyx, these chelices should be cupped, and this is a normal, and they should keep this cup even with compression. But sometimes contrast refill into the renal collecting tubules going into the tip of the pyramid. This should not be confused with tubular extravasation. There is an entity called tubular extravasation, and another entity called medullary sponge kidney, where you can find this cup showing sun ray of contrast. Sometimes during compression you may get this sign, but once you remove the compression you will not get it. So this is due to compression. So normal sun ray at the tip of the pyramid is due to compression, but abnormal persistent is due to medullary sponge kidney and tubular extravasation or intravasation. Compression is intended to see the pelvic system well. Sometimes we resort to do oblique views, and oblique views are of course, to disclose such overlap. Here the minor crevices are overlapped. When you do oblique view, you can see that one of them is directed backward and some is directed forward, but they are normal. They are keeping their cups, with sharp fornices. This one and that one are called fornices. Theirs should be sharp. So the normal cup should be with sharp fornices. Oblique views is done to disclose and overlap. Here is a nephrogram with parallelogram. It's 5 minutes or something like that, where you find good filling of the pelvic cell system with relatively start filling of the ureter. So we can get this nephrogram, and here we have this nephrogram showing smooth outline of the kidney, and this one is also again smooth line joining the tips of the pyramids, or what we call the papilla. So it is like this. These two lines should be parallel to each other, and as we said before, this part should be identical to the similar part on the left side, and again from the uppermost calyx to the top part of the kidney should be identical to that on the left side. So distances should be symmetrical, this one and that one, and the interpapillary line should be parallel to the surface of the kidney. Sometimes you might resort to fluoroscopy to show the ureter, because the ureter has some peristaltic waves usually, and the ureter is showing normal sites of nerving. Three sites of nerving are seen along the ureter: one at the pelvic junction, one across the region of the true pelvis, and one at the terminal end of the ureter. Of course, the bladder here is not filled completely. This is partially filled urinary bladder, and we have as if there is a mass elevating, but here of course this is the levator ani muscle tone, which can produce such an appearance. And as we said before, that the distance between the two ureters is called the interureteric ridge, and the bladder behind this ridge tend to accumulate some urine. It's not a diverticulum, it's just sagging backward, because here the wall is so is thickened more than the wall at this region. So the interureteric ridge is a line joining the insertions of ureters, separating the vault of the bladder and the base of the bladder. Now this is along an vascular examination, or along an angiography for the aorta, showing the contrast after the cortical vascular phase going into the cortical nephrogram phase. That we can see clearly that the cortex is delineating relatively negative medullary portions or pyramids. After a while, if this is 20 seconds after 45 or up to 70 seconds, the whole thing will be opacified, casting the shape of the kidney due to contrast filling into glomeruli and into the lobes of Henle and the renal collecting tubules, because glomeruli are located along at the cortex only, or mainly. Normal gastrogenitourinary tract by CT. I think you have the chance now to see that there is a thin layer of fascia surrounding the kidney, containing fat inside and surrounded with fat outside. And here the appearance is it's not well defined. No, yes, it is there. There is a line here, but it's not well defined like this one. Now, what is this? This is what we call Gerota fascia, and this Gerota fascia is closed up and closed along the lateral aspect, but downward it goes down to blending with the iliopsoas fascia, and any collection outside the kidney within Gerota fascia will be enclosed in a closed bag from lateral, but it can seep down, can go down and reach even into the inguinal canal along with the psoas fascia. Medially, in children, this Gerota fascia is loose and allows passage of the kidney to the other side, as in neuroblastoma. You can see crossing of the kidney to the other side. But in adults, this retroperitoneum is tough, fibrous, and it gives the same behavior of a closed upper and lateral aspect. So in adults it is closed laterally, superiorly and medially, while in children it is closed superiorly, laterally, but medially it is loose. Downward on both children and in adults it is continuous with the psoas muscle fascia, iliopsoas fascia, down into the inguinal canal. Collection of urine can give the appearance of kidney, which is surrounded with urine, downward but not upward, not laterally, not medially. Thus the kidney will be lifted up, so the upper pole is pushed up and the kidney acquires a transverse location, and then the space below is full of urine, and this is called the urinoma. This is the line where we have the Gerota fascia. We have two coverings. One adherent to the kidney is called the renal capsule, and one is this Gerota fascia. Between the kidney and the Gerota is the perirenal fascia or perirenal fat, and beyond the Gerota fascia is the pararenal fat. So we have anterior pararenal fat and posterior pararenal fat, but we have perirenal fascia surrounding the whole kidney and enclosed within the Gerota fascia. This is the appearances of the normal urinary bladder, and you can see here the negative shadow of the interureteric ridge. This is the insertion of the ureter at what we call the vesico-ureteric junction, and here is the region of the interureteric ridge, and here again is the region of the interureteric ridge as the bladder is going down. As you see, some urine is accumulating above the interureteric ridge posteriorly. This is the bladder in MRI and the relation of the bladder into the uterus and to to the vagina, and here is the pubic bone, and this is of course the sacrum. Here is the ischiorectal fossa on each side, ischiorectal fossa, and this is the region of the urethra passing within the prostate. This is the bladder delineated, filled with fluid, and this is the rectum filled with contrast. Sometimes we are doing such a technique to visualize more the interface between the bladder and the rectum. This is a test, and there is a longitudinal line, negative, and vertical line and horizontal line. The vertical line constitutes the separation between the epididymis and the test, while this line constitutes what we call the mediastinum test, and the test is identified by these two. If you see the mediastinum, this is a test. Thank you.